Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. I'm going to do yet another video on, for those of you who don't have an iTero or who don't have the ability or don't have a CBCT or can't use the CBCT functionality in Invisalign or Spark or some of the other aligner companies that are out there that allow you to be able to see if you're potentially moving teeth through the bone. It is actually a game changer. Look, it's getting borderline where this is now standard of care. So if you do not have the ability to at least put the CBCT in the plan to see if you're potentially causing issues, you need to figure out some old school analog workarounds because blindly, 20 years ago when no one had this, we just winged it. Like if things started to happen, then we stopped, and we just watched. And that's why we were seeing our patients every 4 weeks, every 5 weeks in office because we were checking for things. Now you guys are like set it and forget it. You're giving the whole box, you're giving 10, 20 aligners at a time, which is what they're telling you to do in these classes, but you're not checking things. So if you don't have CBCT in the plan, if someone perfs, guess whose responsibility is? It's yours. You're never going to get out of that. You're going to be paying big time. So, and to be honest, it's a matter of time. It's going to happen. It's not a question of if it's going to happen. It's questions of when it's going to happen. I see these cases all the time. I got doctors coming to me stressing, how do I fix this? I don't know. Ask Perio. Damage is done. So, no, I don't know if we can do any more treatment. Damage is done. Yeah, you're going to have to give a refund and then some. Yeah, this is going to be trouble. So I'm not going to sugarcoat it. If y'all fuck it, excuse me, if you mess it up, you're going to have to fix it up. So let's just try to prevent this to begin with. So ultimately, I do think it's better to use an aligner company with CBCT. And those of you who aren't offering it, it's clearly not like a proprietary thing anymore because if Spark's offering it, and Angel's offering it, but that doesn't mean much to me because that's not a US company. But the fact that Spark's offering it and not getting sued, I know it's no longer a proprietary thing. So it's really everyone needs to get their software up to standard of care or up to code. In the meantime, it's just going to be more work for you. It doesn't mean you can't take the cases. You may not want to take the super hardest cases, but for those yellow cases, I always say never take a red case with a case without CBCT in plan. But for those yellow cases, and if you don't know the difference between a green, yellow, and red case, you should go to my YouTube channel, put that keyword in the thing, just put the keyword green, keyword yellow separately. Watch all the content I have about yellow cases, red cases, and green cases. You'll get it. Okay, so without further ado, let's talk about some of the analog options. I'm not saying I do all this stuff. I'm just saying this is stuff that people may tell you if you go to a class, if you ask people. I'll let you know kind of what I do. First of all, I don't know, man. If it's a advanced yellow case or borderline red, just don't take a ClearCorrect case. Just don't do it. Don't do it. Dibs AI, aka former Ortho Select, they have CBC functionality in their braces. So why don't you check that out? They're only like a couple $100 per case if you do volume. Okay, so first option is the palpation technique, and I'm gonna refer you to a few videos that I've made that go more into these things, and I may call it different things. So palpation technique, aka I call it washboard roots. So that video is called washboard roots. You can just look to washboard as a keyword. So basically you're using your fingers at every visit, before the tray changes, and checking the ridges and checking for root dehiscence chances, protrusions, washboarding of the roots. And of course, if we start feeling washboarding, we ain't gonna, if the plan has you going more out or more forward, we're not doing that. We're gonna tuck them back in and do a refinement. So that's all it is. Every time they come in, and if you're doing this type of case, you have to see them every 4 to 5 weeks. And if they no show an appointment, they don't get more trays. They gotta come in. And to be honest, if they no show an appointment, you better start that cascade of phone calls, emails, and discontinuance letters because you will be responsible. It's, this is a part of patient abandonment. If you have a patient and you're doing stuff without all the technology and you're not monitoring and you're allowing it to keep going on, you're allowing it to keep going on by not discontinuing the patient and allowing them not to come in. You have to let them know they have to come in. We're not talking about virtual monitoring. They have to come in. Number 2, I would call this the safe plan. So aka IPR all over. And I have a video on safe plan. You can look that up. Just play it safe. Don't do any expansion. Don't do any proclination. Keep the teeth where they are. Just straighten them where they are. Extractions, IPR, all that. So look up safe plan for your keyword. Number 3, this would be really, really, really slowing down the case, which is something I've been telling you guys to do forever on these cases. I tell you to 2.5 to 3x a ClearCorrect case, or you can double it if you do the 0.2 instead of the 0.3, whatever. If you didn't fix your preferences to 0.2, then you should do 2.5 to 3. And I disagree. I would still keep it on 7-day wear, not 14-day wear. That's gross. Just slow it down so it's like 1 millimeter, 1 degree, and they can do 7-day wear. It's so much more comfortable. It's so much nicer for the patient. Let's see. You can use your 2D x-rays. So let's put it this way. If you just have a small FOV and you can't go through the whole stitching FOV process, which you generally can, and if this is an adult, there's no reason you shouldn't be doing that. Yeah, it's going to take you more time, but at least you'll get the answer. But then again, ClearCorrect doesn't allow that, so never mind. I was thinking of Invisalign. You have a small field FOV. You could just look at each tooth segmented and just look at it. Is there bone? You know, a lot of things I can see, you know, just by looking at these. I call these 2D slices, which are slices either from a 3D or they're just a regular traditional 2D ceph. But I mean, I know from my experience, this is a relatively normal lower incisor. This is a flared upper incisor. This is an upright upper incisor. This is a flared lower incisor. Okay. This is a flared upper incisor. This is an upright lower incisor. This is a little flared. This is very flared. This is fenestration. Well, it's CBCT. Looking at this curve of Wilson, these are relatively upright. These are also upright. Sometimes these are rolled in. If these are rolled in, then I know I can probably roll them out and have space. If these are flared, you know, or if these are buccally tipped, then I know I can't expand. This is just all it is. You look at each tooth, one tooth at a time, segment it, look at it through your various slices, sagittal slices, AP slices, you know, transverse slices, whatever you're doing. And you'd have to do that. That involves taking x-rays, you know, every appointment, maybe 2 or 3 appointments. It's a lot of radiation. I don't love that. So the difference between doing that and having the CBCT in the plan to begin with is that's using AI or predictive. Is it completely accurate? No. But I don't like the idea of taking x-rays every 2 to 3 months either. You know, that's not great, but that's how we used to do it, right? Lastly, we already talked about washboard roots, but, you know, just basically tissue check, looking for blanching, looking for thinning, looking for sloughing, doing your perioprobing, all that kind of stuff. So basically, I'll kind of give you my overarching summary. So look, I'm cool with Straumann. I just think that if you're going to take a harder case, you better be really cautious. If you have a severe adult crowding case without a CBCT, your default workflow shouldn't be expand and pray. So someone used that. I love that, expand and pray. Treat the cortical plates like they're solid brick wall. If the patient can't grow and you don't want extractions, IPR is your best friend. You know, slow it down, safety net, use your eyes, use your fingers, use all your senses, and your scanner if needed. Keep everything in the proper digital envelope. Look at the face. I mean, just use common sense. Use common sense. You can't just set it and forget it, or what do we call it? Expand and pray. So, all right, hopefully that was helpful. There's always a way to do everything, and it's just about understanding your case.